Hello, and welcome to the Feeling Good podcast, where you can learn powerful techniques to change the way you feel. I am your host, Dr. Rhonda Borowski, and joining me here in the Murrieta studio is Dr. David Burns. Dr. Burns is a pioneer in the development of cognitive behavioral therapy and the creator of the new TEAM therapy. He is the author of Feeling Good, which has sold over 5 million copies in the United States and has been translated into over 30 languages. His latest book, Feeling Great, contains powerful new techniques that make rapid recovery possible for many people struggling with depression and anxiety. Dr. Burns is currently an emeritus adjunct professor of clinical psychiatry at Stanford University School of Medicine.
Hello. What's your name?
Rhonda.
Rhonda.
Hello, David, and welcome to all of our listeners. This is the Feeling Good podcast, and it's episode 476. It's a special episode. David, can you explain what it is?
Yes, Jill and I kind of have this philosophy of giving away things for free. And so Jill and I have recently been doing free 2 and 4 hour webinars, and also for the general public and for mental health professionals. And it's been kind of fun. And this one was on September 11th. And podcast viewers said they like it when we turn these 2 hour webinars into podcasts. And because we also publish them on YouTube. And I was afraid we were getting, too much exposure, but people said, no, they want us. So let us know if you change your mind. But this was a 2 hour webinar on the treatment of anxiety disorders, which is very, very popular. There's just so much anxiety going around, and, particularly in this era where there's so much hostility and uncertainty. But I think there was tremendous anxiety even, 50,000 years ago or 50 million years ago when humans were first evolving. I think they were just as anxious as today. And as somebody who has struggled with, many, many forms of anxiety in my life, I've taken a great interest in treating it. And so Jill and I did this workshop, and it's been exciting because we had over 2,000 people registered for the workshop, which was just fantastic. And working with Jill is a little like working with you, Rhonda. I know I'm working with a pro who is filled with brilliance and warmth, and the feedback we got was pretty much over the top. But anyway, in part 1 of the 2 hour workshop today, we're going to start out by focusing on the treatment of anxiety in general, and going over not only how TEAM works, TEAM, but also the 4 models that we use in treating every patient with anxiety. You see, some people think they can take a method and treat a problem, and I never do that, and I condemn all who do. I think it sucks, and I think it's stupid. You'll capture some fish, but you'll lose an awful lot. And I work with everyone with TEAM, TEAM, sequentially. And if someone has anxiety, I use 4 models, not 1. And of course, exposure is the big deal. Everyone thinks you have to use exposure, and this workshop is going to focus on exposure and all the subtle points of exposure. But we also will talk about the vitally important motivational model, dealing with outcome and process resistance. What are they? And how do you work with them, with someone who's anxious? And why is it so important? Why can't we just ignore that? And then there's the cognitive model and the distorted thoughts that are always going on when someone is anxious. And also we'll show what's familiar to some of you, but not all of you, the amazing Terri video. You'll hear it on audio, but if I can find the link, we can you'll be able to link to it on YouTube and watch it. It's one of the most remarkable videos in the history of psychotherapy. And you see a woman who struggled with horrible panic disorder for 10 years and incredibly severe depression for 10 years. Nobody could help her. Psychiatrists couldn't. The cardiologists couldn't. She kept having panic attacks when she thinks she's about to die. And then I used a powerful cognitive technique, the experimental technique, and you can see her, if you go and watch the video, going from uncontrollable sobbing to uncontrollable laughing in 6.5 minutes. That changed her life. But you'll actually see her aha moment, which hit at about the 6-minute point when she suddenly realized that her negative thoughts were incorrect. And so that's really important stuff. That we also showed a moment. I treated a woman with 20 years of severe obsessive compulsive disorder in the Tuesday group at Stanford, and you'll see the video of the 30 seconds or 15 seconds that changed her life. See her at the exact moment of recovery. And a lot of good stuff like that. And then in part 2 next week, we'll go into and feature Jill a lot and her brilliant teaching on exposure therapy techniques and what to do and what not to do and what are safety behaviors and all kinds of really powerful fine points. So I hope you enjoy part 1 today, and look forward to part 2 next week.
Hi, everyone, and welcome to our webinar, CBT and Exposure Techniques That Work. We're so glad that you're here joining us today, and we have a lot of exciting material to cover in the next 2 hours, packed hopefully with practical and powerful methods that you can begin using right away. We'll take a couple of questions at the end, and we'll also share some opportunities for you a little bit later in the workshop as well. And first, I want to say that I'm thrilled to be joined by David Burns today. And I imagine that all of you know who David is, but I will just let you know, in addition to being a world-renowned psychiatrist and CBT legend, David is a dear friend and colleague of mine, and I always feel really honored to present with you, David. And David is one of the most influential figures in cognitive therapy and the creator of the TEAM CBT model that we'll be diving into quite a bit today. And he's also the author of Feeling Good and Feeling Great, and the creator of the Feeling Great app, which you'll have a chance to learn about a little bit more today. And I'll also just tell you a little bit about who we are at Feeling Good Institute. So our mission at Feeling Good Institute is to elevate the practice of therapy so that patients can recover faster and more fully. We train and certify therapists in TEAM CBT, which is this powerful framework developed by David. And we help therapists walk through kind of a 5-level certification path. I'll also just share with you very briefly our sort of origin story. So Feeling Good Institute was founded by Maor Katz, Angela Crum, and myself. We had all trained with David in TEAM CBT at Stanford. And back then, the only way to learn TEAM CBT and to learn was to study directly with David, either in this kind of Tuesday group at Stanford, which you often hear people talk about, or going to one of David's intensives kind of around the world. And so we started Feeling Good Institute with this big dream to make David's tools, techniques, and training style more accessible to more therapists without compromising depth or quality. And everything that we do today still reflects that kind of original intention, which is to help therapists to get better so their patients can too. And at Feeling Good Institute, we don't just teach techniques, but we really try to replicate David's training style, which is built on this kind of foundational idea that you only get better through practice and feedback. And it might surprise you to hear this, but experience alone doesn't make therapists better. Doing more therapy sessions doesn't necessarily lead to more outcomes. Sorry, I just had something else pop up on my screen. Let me make sure that closes. Sorry about that. And so the question is, what does work, right? So learning, practice, getting feedback, practicing again, that's what actually drives change. And that's what we emphasize in all of our trainings. And we'll tell you a little bit more about how we do that, later today. And so I'll also just ask you this kind of thought experiment, which is, we've talked a little bit about how experience alone doesn't lead to better outcomes and that real growth comes from focused learning and practice and feedback. So I'd ask you to think, what would change for you if you had a structure for consistent growth? And would that be worth exploring? And so we'll share with you more at the end of the day today, but we have created a kind of pathway to help therapists learn, practice, and grow and become really kind of experts in this TEAM CBT model that we'll be sharing with you later today. So what we'll be teaching you is kind of the tip of the iceberg. And if it's exciting to you, we hope that you'll take the next step with us and join us in the fast track program that we've developed. So now let's kind of tell you a little bit about the framework of TEAM CBT. This is what's been developed by Dr. Burns. And so the T in TEAM stands for testing. And that means that we teach and we use with our patients measures at the beginning and end of every therapy session, measures of symptoms and also measures of the therapeutic relationship, so that we can track progress over time, hold our patients and ourselves accountable for really bringing about meaningful change. And so we can address alliance ruptures or issues that are coming up in the therapy session right away. And we won't really be teaching you more about the T or testing, but we want you to know that we use this with all of our patients, and it's an important part of doing effective therapy. And the E in TEAM stands for empathy, and that means that we have tools and techniques for really connecting with our patients, and especially our difficult to connect with patients, and that we don't just jump in and throw methods at our patients, but we actually are measuring and we're connecting and we're empathizing before moving along and using kind of powerful CBT methods. And the A in TEAM stands for assessment of resistance. That's that we're working on kind of understanding, articulating, and then melting away resistance to change and boosting motivation. And we'll tell you a little bit about that today. But finally, what we'll be focusing on most today are the methods, the M in TEAM, which stands for methods, and we'll be focusing on cognitive and behavioral methods today. And just to sort of share this slide with you is just, we want you to understand that there is this really kind of powerful framework that you can learn and work through to help kind of all of your patients. It's transdiagnostic, and it's not a manual for doing therapy, but rather kind of a framework that all effective therapy includes. So now we'll kind of turn to today's specific topic, which is treating anxiety. And specifically, we'll talk to you today mostly about treating anxiety using exposure and also some cognitive interventions. But we want to make sure you're aware before we start that there are at least 4 important models for anxiety causation and treatment. And David, I'll turn it over to you at this point if you want to just mention the 4 models on this slide and then walk us through kind of what each of the models are about on the next few slides.
Yeah, sure. These are 4 really powerful models for understanding and treating anxiety. And the motivational model focuses on resistance. And there's 2 kinds of resistance that all anxious patients will have. And we'll talk about that in just a moment. The cognitive model stresses that all anxiety results from distorted thoughts, and that it's impossible to change without challenging and crushing those distorted thoughts. The exposure model is quite different, and it says all this other stuff is a bunch of crap, and the cause of all anxiety is avoidance, and the cure is exposure. And exposure always works, and everything else never works. And then there's the hidden emotion model, and this states that niceness is the actual cause of anxiety, and an important, powerful tool is that the bringing suppressed feelings to conscious awareness and expressing them and dealing with them. If we'll go to the next slide, I'll just give a slight expansion on these things. The motivational model talks about two types of resistance: outcome resistance, which means that the anxious patient comes wanting treatment for OCD or a phobia or social anxiety, but that he or she will actually, or they will actually resist a positive outcome. And this is because of magical thinking in most cases. They think that my anxiety is painful, but it's protecting me, it's helping me. And if my anxiety went away, some catastrophe would occur. Process resistance is that the patient might really want recovery from anxiety, but is unwilling or very reluctant to participate in the process, the thing that they'll have to do to recover, which in anxiety is exposure. And exposure is not the only treatment for anxiety, as some of the early, exposure therapists were claiming, but it is mandatory for every patient to include exposure in the treatment package. And then the cognitive model focuses on distorted thoughts, and there's 4 types of cognitive distortion from my list of 10 basic ones that are always present in anxiety. One is fortune telling, and that's predicting that something terrible is going to happen. And it's impossible to feel anxious without fortune telling. It's also impossible to feel hopeless without fortune telling. And mind reading, of course, is the idea that you know how other people are thinking and feeling about you, and that's usually not the case. But this is very common in social anxiety when the patient is thinking, oh my gosh, everyone here is confident, and they could all see how anxious I am, and no one would be interested in me or my life or what I have to say. Magnification and minimization is, I also call it the binocular trick. It's when you blow things way out of proportion. And, patients with panic attacks that you'll see in just a few moments are saying, oh my gosh, I'm on the verge of dying, or I'm about to lose control and end up in a psychotic episode. And anxious patients also minimize the safety in a situation and their own coping skills. And finally, emotional reasoning is reasoning from how you feel. And I know most of you are familiar with these distortions, but for anxiety, it's, my gosh, I'm feeling anxious, I'm feeling scared, I must be in danger. So the anxious patient might think, oh my gosh, every time I get around an airplane, I get terrified. It must be terrifying to take an airline flight. That's extremely dangerous. I can feel how dangerous it is. And then in the cognitive model, challenging negative thoughts is felt to be the cure for anxiety. The very moment the patient stops believing the thoughts that trigger the anxiety, in that very instant, the anxiety will disappear. You'll see this on video this morning. The hidden emotion model is one that I created based a little bit on the psychodynamic or psychoanalytic training I had as a psychiatric resident. And that's that if you ask, if you talk to 1,000 anxious patients, you'll find 1,000 extraordinarily nice people. And the idea is that the anxiety-prone patient is afraid of conflict, afraid of displeasing people, and is constantly focused on meeting other people's expectations. And that is actually causes the anxiety, that there's some hidden problem always that the patient isn't telling you about because they've suppressed it and pushed it down under conscious awareness. And the hidden emotion model involves bringing that problem to conscious awareness and expressing the feelings. And this is a super powerful model. It's hard for therapists to get at first because they don't believe it. And it's not occurring with every anxious patient, but it is with a good 60% or 70% of anxious patients. And once you learn how to do it, it gives you another powerful model for treating anxiety. And among these 4 today, we're primarily going to be focusing on the exposure model. And the exposure model, again, is based on the idea that avoidance is the main cause of anxiety, and avoidance maintains anxiety. And if you've ever struggled with anxiety, you know how overwhelmingly valid this is. If you're afraid of elevators, you avoid elevators, and that avoidance maintains and creates your anxiety. And the exposure model states that exposure is the cure. Now, the cognitive therapists will argue, and you'll see this today, that exposure isn't a cure for anything, and that the reason exposure is effective is because of the cognitive dynamic. In other words, during exposure, the patient suddenly sees that their belief that elevators are dangerous, for example, that sees that it's not true, or the panic attack patient sees it's not true that they're about to die of a heart attack or about to go crazy. And so it's kind of interesting to look at the exposure through these two different lenses, the cognitive model and the exposure model. And they're two very powerful and helpful models for sure. Now, I'm going to give you an example of the overlap between the cognitive and exposure models with a very severe problem. Terri was a woman who came to me for treatment in Philadelphia after 10 years of extreme depression and anxiety. And at the time, I was using a depression and anxiety test, long versions of my depression and anxiety checklists that were scored from 0 to 100. And I think she had a total score of 199 on those two tests. And at the time was by far the most severely depressed and anxious patient I'd ever seen in an outpatient setting. And her problem was she'd been having 5 panic attacks each week. And during the panic attack, she gets tightness in her chest and gets dizzy and develops the belief that she's about to die of a heart attack or a stroke or pass out, or that she can't breathe properly. She'd been to many ER visits, had been worked up by many cardiologists, pulmonologists. Eventually, they diagnosed panic disorder. And after 5 years, she was referred to psychiatrists, and they treated her with massive doses of just about every known psychiatric drugs, and that didn't work, and psychotherapy didn't work. And she felt not only panicky, but intensely ashamed, demoralized, and hopeless. Now, when I'm working with an anxious patient, I always work with their daily mood log. And you can see here on the slide Terri's daily mood log. And it's like the upsetting situation is that she senses a panic attack coming on. Now, again, this happened to her 5 times every week. And, she gets somatic sensations. And the cognitive model of panic is the misinterpretation of benign physical sensations. And but when she gets upset about something, she hyperventilates subconsciously. She doesn't realize she's doing that. But if you do that, you blow off too much carbon dioxide, and your blood pH changes. And that creates the symptoms of anxiety, the numbness, the tingling of the fingers, the chest feels tight, she gets dizzy. And then all of her feelings, as you can see that she's circled, depressed and terrified and ashamed and inferior, discouraged, embarrassed, and frustrated, are all at 100, the worst a human being can have. And the anger was the only one that wasn't 100, and that was 25. Now, the cognitive model states that the 100% and only cause of these negative feelings are her distorted negative thoughts. And she's telling herself, I can't breathe properly, and she believes that 100. And if any of you right now believe that you couldn't breathe properly, you too would suddenly become panicked. So she believes that 100, and my windpipe is closing off. She believes that 100. If I stand up, I'll pass out. She believes that 100. I'm about to have a heart attack. She believes that 100, and I'm going to die. She believes that 100. Now, on the next slide, you'll see what I call a recovery circle, and this is a cognitive technique, and the thought that she wanted to work on, we're putting in the middle, I'm about to die. And I always think of 5 or 10 or 15 or 20, or in the old days, sometimes 25 or even 35 cognitive techniques. I've learned or developed over 150 techniques now for crushing negative thoughts. And so I put many up there on the recovery circle, and the idea is called fail as fast as you can, that the faster we go through these techniques and fail with them, the quicker we'll get to the one that works. And so over the course of about the first, I'd say 3 or 4 sessions, I tried a good 15 techniques, double standard technique, examine the evidence, downward arrow, hidden emotion, examine the evidence, feared fantasy, identify the distortions, all this kind of thing. But everything was pretty much 0% not helpful to her. She came back every week with the exact same incredible scores on the depression and anxiety test. And so I told her, Terri, I've used a lot of gentle techniques with you, and they're just not working, which is okay. But next session, I'd like to try one of the most powerful of all of the cognitive techniques for anxiety, called the experimental technique. And what I'd like to do is induce an actual panic attack during the session. And then during the session, I'm going to teach you to do some experiments to test to see if what you're telling yourself is valid. And she said that she thought that was a wonderful idea and got all excited and went home and called in and left a message that she was canceling her next 2 therapy sessions. And I guess she was terrified and was too nice to tell me that I don't want to have a panic attack in your office. And she left a note, a message saying that she wasn't firing me and that I was the best therapist she'd ever had, but does she have to have a panic attack in my office? And she's too terrified to do that. And so we spoke on the phone a couple times, and I was able to persuade her to come in. I said, we'll have a double session and we'll have plenty of time. And we're here in the hospital. The emergency room is right down the hallway from my office, and I really want you to take a chance. And that's one of the teaching points for today, was that I had been getting perfect scores on the empathy scale, so I knew she really liked me and trusted me. And that gave me the license to really push her when it comes to exposure, because almost all patients will strenuously resist exposure. And so I had to persuade her, it was pretty forcefully, to come in and try this experimental technique. And so what happened, she came in, and I told her to close her eyes and hyperventilate like that, because I knew she'd start getting the symptoms. And I said, now move your finger when you feel the symptoms coming on. And after about 15 seconds, she wiggled her finger. And then I said, now I'm going to be the voice of your panic attacks. And I'm just like that voice in your head. And I'm telling you that you can't breathe properly, and your fingers are tingling, and you're about to have a heart attack. And we're going to have to call for the paramedics, and they're giving you oxygen, but even that isn't working. And they're panicking, and can you see the red light on the ambulance going round and round? And this triggered a massive panic attack, and she started sobbing. Now, I just happened to have a video camera in my office, and I had all my patients record on video or audio all their sessions and either watch them or listen to them at home. And she was one who had allowed me to videotape, and that's why I have this actual excerpt from that session, which, of course, she's given permission for me to show. And we're just going to cut right into the point where I've just induced the panic attack, and she's sobbing, and she starts begging me to stop. Let's see what happens. Oh, by the way, just stop it for just a second. Yeah, and I want you to ask yourself, whether you're a therapist or a general citizen, 3 questions when you see this video. You're going to see wild fluctuations in her feelings. Ask yourself, first of all, what is causing the fluctuations in her feelings? A second question is that she's begging me to stop. And if you were the therapist, what would you have done? She's stopping, say, please, Dr. Burns, you're going to see this. I can't go on. We must stop. And then what would have been the consequence of stopping or pulling back if you had done that, or the consequence of pushing ahead? And And then if you have any, general theories about if she's improving or getting worse during this excerpt from her session, what are the causes of that? What's going on here to the best of your understanding? Now let's see what happens.
Experiment and find out if it's true that you can't take a deep breath.
My fingers feel numb.
Do they feel numb? That's another symptom of panic and anxiety, and I'm glad that you're allowing yourself to get real anxious. How anxious would you say you are right now, between 0 and 100?
Like 100.
About 100, about maximum right now. Now, if you couldn't breathe right now, why would that be a problem to you?
I feel like I'm going to die.
Mm-hmm. What would you die of?
Don't.
Lack of oxygen?
And my heart. My chest hurts. My chest hurts so bad.
Mm-hmm.
And this always happens.
Yeah. Now, what are some experiments that we could do to find out if your heart is working properly and if you're able to breathe properly right now?
I don't want this anymore, please.
Mm-hmm.
Just.
Well, I'm going to ask you to bear with it so you can kind of put an end to this fear that you have once and for all. Do you think the person who can't breathe would be able to exercise strenuously? Okay, do you think that you could exercise strenuously right now?
And I don't.
Why don't we find out what would be some strenuous exercise that you could do here in the office to find out whether or not you're breathing properly and your heart is working properly? Well, what's the most strenuous exercise you do? Jumping jacks, running in place?
I don't know. I walk and I ride my bicycle.
Yeah, but we can't do that in here unless you have a unicycle or something. Okay, good picture, but I don't think we have one here. What's some exercise you could do right here to test the belief that you can't breathe? How strongly do you believe right now that you can't breathe?
It's getting less.
How strongly did you believe it?
Oh, like 100.
Okay. Well, how about just running in place? Would you be willing to do that? You ever do jumping jacks, running in place, push-ups? Not push-ups. Yeah, push-ups, running in place, jumping jacks.
I don't know. I'm afraid if I stand up, I'm going to pass out or something.
Okay. Well, let's check that out. See if you can stand up and run in place. Okay. Now let's see if you can do some. Let's see if you can do some running in place right now. Go ahead.
I really feel dumb.
Well, run. That's okay. I mean, you might have to feel dumb to get well, but it would be worth it, I think, if you got well. How much? See if I can focus this thing on the exercise there.
I feel really dizzy.
Okay, we'll just keep going. Now, how strongly do you believe that you can't breathe if your heart isn't working?
About 70.
You believe 70% that you can't breathe?
Uh-huh.
Mm-hmm.
I mean, I shouldn't be having to breathe. It's heavy. It's a little bit of.
Mm-hmm.
And I still can't take a deep breath. And it's like.
Can you run more strenuously? Faster? Mm-hmm. You do aerobics? Do you do exercising? A little bit? See if you can back up just a little bit.
Sorry.
There we go.
My fingers feel numb.
Okay. How strongly do you believe that you can breathe right now? How strongly do you believe that you can't breathe?
Let's see.
I feel better, like 60 that I can.
You believe 60% that you can or cannot?
That I can.
You can breathe.
That I can't.
Can. Okay, it's down to 60. How about some jumping jacks?
I feel too dizzy.
We'll try some jumping jacks anyway.
Yeah, if I was dying, I couldn't.
Well, could you do this if you were dying? This is what you see in emergency rooms, people with heart attacks doing jumping jacks.
No.
Well, keep doing the jumping jacks. I'm sure you'll pass out at any moment.
My hands feel weird.
Yeah.
Whoa.
Oops. How strongly do you believe now that you can't breathe?
About 50.
50, it's going down. Just keep up the boots. You've got to keep jacking until it down to 0. We're going to get a 0 out of you for no other reason than fatigue.
I do. I feel a lot better.
Okay, sit down right now then.
And now let's just see what the audience thinks about some of the questions I asked. First of all, there was a massive change in 6 minutes there. That was actually her first recovery after 10 years of failed medical and psychiatric therapy. Heart evaluations, lung evaluations, pill after pill. And you can see that her all of her symptoms went to 0. She wasn't just feeling better, but it was totally abolished the system, and she was able to blow all of these negative thoughts out of the water. But what was it about that experience was one question that, why did her feelings go from uncontrollable sobbing to uncontrollable laughter in 6 minutes? What was the healing mechanism? And secondly, how many of you would have backed off if you were the therapist rather than pushed ahead, and what would have been the implications of that? And maybe, Jill, you can check the chat and see if we've got some answers to those questions.
Exactly. Yep. So I have someone, I'll read to you right now. So it seemed really helpful to ask again and again to rate her strength in the belief. Someone proposed, was it that she was distracted from her symptoms? Someone said the exposure led to a shift in her thinking. Someone said because the more you pushed her to do it, she could run and talk, and that helped her realize that she was still alive. You also got some, tell me if you, I was going to put a couple other comments out there, but mostly, so some people said distraction, other people said like change in thinking, realizing she was not dying since she was able to do jumping jacks.
Yeah, I think most of you have it pretty much on target. This distraction is a mildly helpful technique for all negative emotions, but it's very temporary and a weak sister of the 150 techniques I use. I would say it's the least effective, and that was not the reason. But it's great thinking on your part why she had this profound change in her emotions. But it was because when she was doing the jumping jacks, she said, "I wonder if I could do this if I was having a heart attack." And then I said, "Is this what you see in the emergency rooms of hospitals? Patients with massive heart attacks doing jumping jacks next to their gurneys in the emergency room." And then she started laughing so heavily that she doubled over with laughter. And then when she stood up, I said, "Keep up the jumping jacks. I'm sure you'll pass out at any moment." And then she said, "Oh, hey, I'm feeling a lot better." And then in the session, I repeated that demonstration one more time. I induced a second panic attack with her permission, and just so she could see that it was something she could reproduce. And she again thought she was on the verge of death, and I got her to do the jumping jacks, and then her emotions went all the way to 0. Then she had some questions about what if she gets a panic attack at home, and a few other things that were kind of fun and funny to deal with. But in the interest in time, I'll just say that the one question you might have is, did this last? Was this responsible therapy? Because it seems kind of scary, and it definitely takes courage on the part of the patient and courage on the part of the therapist. I knew, of course, that her negative thoughts were distorted and just not possible. It would have been impossible for her to pass out when she stood up because her heart was racing and her blood pressure was elevated. And fainting is associated with a drop in blood pressure and a slowing of the heart. And, everything she's telling herself is just extremely distorted. But it also shows the hypnosis of the patient. She's trying hard to hypnotize me into believing what she's saying and giving up. And if I had given up, it would have torpedoed the treatment. And I've had to call her. That was 35 years ago. Or almost 1988. You can calculate the years, and 40 years anyway. And I call her every year or two to say, how are you doing? And she says, tell your audiences, and can I show this? Because she was so ashamed initially. And she said, I hope you show it to everyone in the United States, and just tell them that I'm still doing great. And she had another child, and which was one of her goals, because they had 4 children, and the previous psychiatrist said she couldn't become pregnant because of all the psychiatric drugs she was on. So he said they might cause a birth malformation, but she was able to go off of all of those drugs and had only one panic attack in the last 35 years, and she called me for an emergency. It was years after this. And I said, well, do your jumping jacks. And I'm doing a workshop today. I just showed this video at a workshop. And then she called and with an emergency. And I said, I'll be home tonight and I can see you tomorrow. And then she called again at the end of the day and said, cancel the appointment. I did my jumping jacks and I started laughing again, and my panic attack disappeared. But anyway, that's a thumbnail of that should teach you a great deal about the cognitive model and exposure. And the question is, was it the exposure or the change in her belief and her negative thoughts that triggered the sudden change in her feelings? And I would argue that in this case, in many cases, the reason the exposure worked was because she suddenly realized the nonsense of what she'd been telling herself.
And David, just wanted to point out, lots of people brought up some things that we will be talking about throughout the day today, which is, people saying, oh, I would have given up because I would have been anxious, and also people realizing if I had given up, I would have perpetuated her belief that she was unsafe,
Right.
Another failed therapy.
Yeah. If I'd stopped, she would have said, even my doctor, who's a medical doctor, is frightened. This must be a real thing. So by backing off, which, we're all tempted to do, it would have been horribly destructive for her.
Yep, exactly. So it's a lot of people realizing that, people also saying, wow, that's amazing, you're so brave, and also commenting on your sense of humor being a part of what was effective as well, which I think is really true. And
just to comment briefly on that, the Buddhists have a form of enlightenment called laughing enlightenment. And that's when you finally confront the monster that's been ruining your life and all of your previous reincarnations. You discover that the monster has no teeth, and you go into uncontrollable laughter and then go to nirvana or some kind of Buddhist heaven. And that's exactly what Terri was experiencing, was laughing and enlightenment. And I use a lot of humor in my therapy.
Yes. And I'll also just tell people, if you have questions for us throughout the webinar, we won't be looking at the chat, but Mike Christensen is helping us. And so if you do send questions about the content or questions about exposure in the chat box, Mike will be compiling them. And at the end of the 2-hour webinar, we'll go through some of your questions. We'll have a chance to answer some, although probably not all of your questions. So we've got a lot to cover here. I think you probably covered this, David, but is there anything else you wanted to say?
Well, I just think that some of the teaching points is that thoughts are the cause of negative feelings, and that when you're upset, generally your thoughts will be greatly distorted, as hers were, and that recovery can happen rapidly at the very moment you stop believing those thoughts. And the way you find the technique that works is by failing as fast as you can. And also, patients will fear and resist exposure. She was begging me to stop. And, the consequences of stopping would have been catastrophic. But exposure requires strong empathy and trust. The empathy alone won't do her any good. I was getting perfect empathy score for several weeks before we did this, but her symptoms didn't change. Empathy is not curative for anything, but if without it, you can't go on to the powerful techniques that will cure the patient. And the reverse hypnosis is what you'll be telling yourself as a therapist. The patient will be convincing you, oh, my patient is too fragile for exposure. What if I re-traumatize him and her? And I saw a lot of people talking about, oh, is David going to re-traumatize her? And, this is so terribly dangerous, and it's responsible to think about those things for sure, but not get trapped by them. And some therapists might think, well, what if my patient acts out violently or attempts suicide? These are some of the consequences of reverse hypnosis.
And so we'll do a quick poll here with you guys just to understand. Some of you answered this, but we'll do it in the version of a poll so you can all actually answer. So the first question on the poll is, would you have been tempted to back off when Terri begged David to stop? So go ahead and answer that. Yes, no, or maybe, but try and answer yes or no. The second question on the poll is, do you fear and resist using exposure with your patient? So if you're a therapist, are you fearing and avoiding exposure? So either kind of, yes, I avoid exposure. No, I don't avoid it, meaning I use it happily, or I sometimes avoid it due to my own fear. And the last one, since we're all human here, and some of you are not therapists, just members of the general public, but also as therapists, we all have fears. So do you fear and resist using exposure with yourself, whether you're a therapist or a patient? Kind of, yes, I do. Avoid exposure. No, I don't. Or a kind of, I sometimes do. And I'm going to give you guys another 10 seconds, let's say, to answer quickly. Try to get maximal participation here in the poll, and then I'll end the poll and share the results. Okay. So we can see 50% of you said I would have backed off when Terri was begging David to stop. And we have, let's say, do you fear and avoid using exposure with your patients? We have 16% yes, I do. And kind of 47% saying sometimes I avoid, right? So only about 39, or let's say 40% of therapists saying I never avoid using exposure. I'm kind of confident in using exposure, right? So 60% still needing to be convinced. And then do you avoid it yourself? Again, we've got just, let's say 30% saying I don't avoid, and the rest saying either I do or I sometimes do.
So I think the poll was great in showing that a lot of patients and therapists alike are really fearful of exposure and avoid using it.
Absolutely. And so hopefully we're going to help you to feel less afraid of using exposure with your patients and with yourself, and also give you some tools and techniques to actually make exposure more effective. But yeah, our take-home message so far is that exposure can be incredibly powerful, as you could see in the video, but also can be really challenging for patients and therapists alike. And we've talked a little bit about this, but some of the keys for successful exposure are empathy, right? Some of you commented that in the chat box as well, that Terri must have had an immense amount of trust in David. Also, skillful assessment of resistance. David, I don't know if you want to comment on that as it relates to Terri?
Well, there are the two forms. There's outcome and process resistance, and you have to do those before you go into any method. That's the key to team therapy. First of all, you got to get an A or an A+ on empathy, and then you've got to have skillful. The outcome resistance is that if I lose my anxiety, something terrible is going to happen. I'm suffering, but I need this anxiety, or I'll flunk out of college, or
In the case of a panic attack, quite often that outcome resistance is if I'm not hypervigilant, then maybe something bad really will happen.
Exactly. I need this anxiety, or I'm going to have a heart attack.
Exactly.
I have to sit here motionless, type of thing. Right. And then, of course, the process resistance is the very intense and totally understandable resistance to exposure, and the patient and therapist get involved in a folie à deux. In other words, an insanity shared by patient and the therapist that somehow exposure is highly dangerous and needs to be avoided. And that you have to really persist when the patient resists during actual exposure. Terri begged me to stop. And therapist confidence, your self-confidence, your persistence is the crucial key to success. And the patient's resistance is not just for panic attacks, it's for every single type of exposure. That you come to the point that the social anxiety, you want them to smile and say hello to strangers. You can go out with them doing this, and they're going to stop and resist, and you're going to have to push them. And that's where you need the trust and the empathy, so you can push them. And you have to have the determination with yourself that you are going to push them. And if you're the kind of therapist who just thinks that support and talking are the key to therapy, you're going to have a lot of long-term patients, but you're not going to have a lot of cures.
Yeah. And and I was going to say that in this particular training today, we're not focusing on tools and techniques for overcoming resistance, but we think those things are incredibly important. And we do a lot of teaching and training in the Fast Track program, in our free trainings, where we really focus on outcome resistance and process resistance. But we will be focusing now more on methods.
Yeah. And if you want, Jill and I might offer another one of these free webinars on the resistant patient. And Absolutely. Then because we have a ton of new innovative techniques for dealing with resistance, and most therapists are not familiar with them.
And one other thing we'll highlight here, and then we'll also give you some clinical examples of throughout the webinar today, is this concept of safety behaviors. And so I'll mention it now because it relates to something you saw in the Terri video, and then we'll talk some more about it with some other clinical examples. But a safety behavior is essentially anything your patient does in the moment when they're anxious to reduce anxiety. And we use that very general term because very often patients will come into therapy thinking that they have all these great coping strategies, right? When I feel anxious, I make sure I have my medication with me. I say a prayer or a mantra. I, wiggle my fingers.
Let's see the next slide, Jill.
Okay, I'll do that in a minute. But essentially, the thing about safety behaviors is that in the short term, they make patients feel better, right? In the short term, they give you a sense of relief and even a kind of illusion of control over your anxiety. But in the long term, safety behaviors actually make anxiety worse because they don't allow you to learn that nothing terrible actually would happen, that you don't need the safety behavior in order to feel better. So they prevent new learning. And as you saw in the example, new learning is what happened for Terri, right? She needed to experience an intense amount of anxiety and to do those jumping jacks to learn that she was, in fact, safe. So on this slide, I have some examples of safety behaviors. And so for some people, it could be, carrying a lucky charm that makes them feel less anxious. For a patient that I actually just evaluated this past week, he told me that even though he didn't take benzodiazepines, he carried his container of benzodiazepines around with him, and he didn't see that as harmful. But see, in my mind, I'm seeing that he's telling himself, I'm not okay. And I know that I have this escape valve just in case. And so he's not actually learning that he is safe, that nothing terrible would happen. For some people, a meditation or a mantra or a ritual, Again, nothing wrong with waking up in the morning and doing some deep breathing or meditation as a sort of strategy for feeling good. But if it's something you feel like you need to do in the moment in order to not feel anxious, it's counterproductive. We have a couple other examples. I don't think I need to go through all of them, but patients with OCD quite oftentimes will be seeking reassurance from others, and they'll repeatedly ask for reassurance. It makes them feel better in the short term, but of course maintains their anxiety in the long term. Patients who have a fear of illness or a contamination anxiety will oftentimes carry hand sanitizers. They'll wash their hands repeatedly. So we just want you to get the sense and realize in your mind that there are a lot of things patients will do during exposure that's actually really counterproductive, and we need to be aware of them and we need to address those things. And so just to make it a little more interactive, we'll invite you can share just a few with us in the chat box, and I will read a few of them. So any safety behaviors that you've seen in your patients that I didn't mention already, or that you yourself sort of rely on to kind of white knuckle or get through things when you feel anxious. So I saw someone say leaving the room, right? Right. In social anxiety, oftentimes leaving the room, avoiding eye contact. Someone said carrying a water bottle. Exactly. So someone else might be like, what's wrong with carrying a water bottle? Well, intrinsically, there's nothing wrong with carrying a water bottle. But if one thinks I've got to carry this water bottle in case my mouth is dry, then it becomes a safety behavior and counterproductive. Carrying around a doll from childhood, eating sweets, looking at their phone, right? So distracting oneself. And people are asking, is breathing or things like that, are those problems? Yes, if during an exposure exercise, someone is doing something to try to calm down, ask yourself, is that productive? No, because the point of exposure is being all in, bring it on. I want to feel as anxious as I possibly can when I'm doing exposure. So if I'm doing grounding exercises or breathing exercises, I'm actually interfering with the effectiveness of exposure. There are ways, I will say, I've actually been contacted by therapists who say, can you integrate safety behaviors into a hierarchy? And we'll get into that in a few slides. But the answer is yes, you can, as long as you're aware of the fact that these are things that need to be dropped out and changed over time, and that they can get in the way of new learning occurring. So you guys added tons of great examples in the chat box, but I'm not going to read all of them. We'll move on and we'll give you some more examples of them a little bit later on. I'll just kind of cover this slide, David, and I can turn it back to you for the next example. But there's at least 4 types of exposures. There's in vivo exposures, which is when we're going to have our patients face the thing they're most afraid of in reality, right? So if a patient is afraid of a dog, they're going to hang out with dogs. If we're afraid of heights, we're going to go to high places. There's cognitive exposure, which is where you're helping the patient to confront the thing they're most afraid of in their mind. And we're going to walk you through an example and kind of teach you how to do cognitive exposure. That's especially helpful for exposure to things that you can't actually face in reality. Fears of things that might happen in the future, for example. There's interpersonal exposure, which we're going to do our next webinar, I think, on, or one in the future on, which is kind of a social anxiety exposure, smile and hello, shame attacking exercises. So a variety of exercises to confront social anxiety and interact with people socially. And then virtual reality exposure, which is where you can use virtual reality equipment, sort of similar to mimicking an in vivo exposure. It can help use all the senses to actually make exposure more realistic and helpful for things that, again, you can't easily confront sort of in real life. And then, David, if you want, you can talk about kind of gradual versus flooding here.
Okay, well, I mean, all exposure techniques pretty much can be done gradually or in a flooding way. And as Jill has mentioned, for gradual exposure, you can create a feared hierarchy and have the patient start with the easiest thing. And once they're used to that, go up to the next highest, next most intensely feared thing on their hierarchy, and then do that over and over again. Like for example, if you're afraid of heights, you could just go, the first few times, just go up the first rung of the ladder. And then the second time, once you're not afraid of that, you go to the second rung on the ladder, and you continue this gradually until you can stand on the top of the ladder. Flooding would be hitting your worst fear all at once, and that's what I did with Terri. And also, when I had a fear of heights in high school, I wanted to be on the play, the stage crew of the play Brigadoon, and the drama instructor teacher said you have to do work at heights to be at on the stage crew. And I said, well, I have a fear of heights. And so he said, if you'd like to get over it, we can do it right now. And so he took me into the theater, and there's a big V ladder there. And he said, just stand on the top of that ladder and then I'll wait here at the bottom of the ladder until your anxiety disappears. And that was flooding. And I stood up there for, 10, 12, 13 minutes, and my anxiety was 100 out of 100. I was just standing on the top of the thing, and I kept saying, Mr. Kershak, I'm still 100 on anxiety. He said, well, just it'll go down pretty soon. Just keep standing there. And then suddenly, after about 14 or 15 minutes, the anxiety dropped to zero, and I was no longer afraid of heights. And then I loved being on the stage crew, and I would work up at the ceiling and working on the lights and the curtains and all of that. And I couldn't even remember why I'd been afraid of heights. But both techniques are effective, and it's kind of personal choice.
Yeah, I was just going to say one other thing, David, while we're talking about exposure, is that when I learned, and I'll share a little bit about this later, but when I first learned to do exposure, which was actually kind of one of the first methods that I learned in graduate school, I thought of it in a way as like a way of life for myself, which is, I didn't think I could ask my patients to do something that I wasn't willing to do myself. And so I set out to identify, were there any things that I was fearing and avoiding, and could I go ahead and face those using the same techniques that I was encouraging my patients to face. And David, I think you and I both have a lot of confidence in exposure therapy. And I think that's also because we walk the walk, right? When we do see that there are things that we fear and avoid, we go ahead and we're kind of all in and we face them.
I've had over 17 anxiety disorders since I was little, so I know very well what all the kinds of anxiety are like, and I know very well how to get rid of them and get cured from them.
So we'll talk a little bit about gradual exposure now, and we'll cover flooding in a little bit. But with gradual exposure, the goal then is that we're going to break down the fear into a hierarchy, or like a list of examples of situations where the patient might fear and avoid this thing. And this can be done with any type of fear. So if one is afraid of dogs, we're trying to make sort of a hierarchy of least anxiety producing to most anxiety producing situations, right? It could be little to big dogs, but it could even be watching a movie about a dog. And so I'll share with you guys a fear and avoidance hierarchy that I developed for a patient that I treated for a fear of driving. I've actually treated a lot of patients in my career who have a fear of driving, and I will say I kind of have a soft spot for it because the very first patient I ever treated in graduate school had a fear of driving, and I'll give her example. I was a grad student at Boston University, and my office was right near Fenway Park, right in the middle of Kenmore Square. Very busy, lots of driving going on. And this first patient that I ever treated, her name was Patty, and she had this intense fear of driving. And interestingly, a lot of people think people with a fear of driving, it's because they're afraid of having an accident. Maybe they had a traumatic experience, but actually many patients I treat, it's just that they had a panic attack while driving, and that scared them tremendously. And the fear is that I'll lose control, that I'll crash the car, that I'll pass out while I'm driving. And so just to stick with the fear and avoidance hierarchy, we kind of created a hierarchy together from least anxiety producing to most anxiety producing. So something that felt easy but still a little scary to her was just simply driving to the end of her street, because she had completely stopped and avoided driving, even though she used to drive all the time. And the next step would be driving to her kids' school, which was a couple blocks away, driving to the grocery store. So the point is that you're creating this hierarchy. You can even add things like during the day or at night in a crowded time or at a busy time. And the goal is that you're just creating this list from least distressing to most distressing. And in her case, driving over bridges and in tunnels in Boston was the most anxiety producing thing that she could imagine. And then we essentially use exposure. And I can say with this patient, of course, like with all of our patients, I'm integrating other models. I always start with testing and empathy and also a lot of cognitive therapy to understand what was she most afraid of, right? In her case, she was most afraid of passing out, losing control, getting into an accident because of her intense anxiety. And so then what we did was we practiced together each thing on the hierarchy, and I would do it with her in session, and then I would assign it to her for homework. So she could do it with me, but then she needed to repeat it daily for homework. And we would move on to the next step on the hierarchy when her anxiety rating would drop. So the goal is that you stick with each activity till the anxiety goes down. There's no magic number, but I always say till it's maybe around a 20 or something like that. I also want to just point out, and I can say that with Patty, it was incredibly effective, actually. And I did, do the driving with her, and she was also willing to do the driving on her own for homework. I was super aware with Patty, as I am with all my patients, of what she was doing when we did exposure that might have actually been sabotaging her success. And so she wanted to distract herself. And that was the strategy she had been using to sort of white knuckle it and get through the driving on her own. She would turn on the radio and try to just pay attention to the radio. So she wasn't paying attention to her sensations. She would open the window because she was hot and sweaty. And she thought, oh, that'll make me feel better. I'll be able to breathe better. She would carry medication even though she wouldn't take it. Say mantras to herself like, you're okay, you're okay, you're okay. And sometimes even use the phone to talk to a support person. I also want to point out something that I think is really interesting. My experience with driving phobic patients is sometimes their safety behaviors make them feel better in the short term, but actually were interfering in their driving, which is kind of fascinating. It was making her a more dangerous driver that she was doing some of these things because she was distracted from the road. And that's how you know it's a true safety behavior, right? It's actually causing more harm than good. So we integrated those in the hierarchy. It was important that she dropped out these safety behaviors, both for her actual safety, but also so that she could realize that I can drive and feel anxious and still drive safely. The other thing that I integrated in my work with her is what we call hypothesis testing. And I know, David, you love this technique, and so I'm happy to let you describe it. Did you want to do that?
It's just something I recalled from when I was going to Beck's weekly seminars when I was first learning cognitive therapy, and he just mentioned a patient who had a driving phobia and had the thought, I'll lose control of the car. And so he had her do experiments while driving, not to distract herself, but to test that hypothesis, the same as what I did with Terri, like, can you turn the radio on and off or change the station, the radio station? Can you speed up by 5 miles an hour? Can you change lanes? And then, when she reported back, could you do all of these things if you had lost control? And so it's just a way of integrating a cognitive dimension into the exposure.
And even, with the Terri video, she said, I'm afraid I'm going to pass out. It's like, well, what can we do to test that, right? And so if you have a patient who's saying, I'm afraid I'm going to lose control, we're saying, what's an experiment we could do to test that? Can you do A, B, and C? And I do find that to be very effective with, particularly driving phobia, but in general with doing exposure, is making sure that you're testing that hypothesis.
This has been another episode of the Feeling Good podcast. For more information, visit Dr. Burns' website at feelinggood.com, where you will find the show notes under the podcast page. You will also find archives of previous episodes and many resources for therapists and non-therapists. We welcome your comments and questions. If you want to support the show, please share the podcast with people who might benefit from it. You could also go to iTunes and leave a 5-star rating. I am your host, Rhonda Borovsky, the director of the Feeling Great Therapy Center. We hope you enjoyed this episode. I invite you to join us next time for another episode of the Feeling Good podcast.